And with that, I would like to introduce to you Dr. Jill Shapira. It's a great pleasure for me to introduce Dr. Shapira. She is an advanced practice nurse who had worked with Dr. Mario Mendez at UCLA for 15 years, and together they developed the neurobehavior unit at UCLA, which has done such great work for so many. They specialized in caring for individuals with frontotemporal dementia and young onset Alzheimer's disease and their families. And Jill designed very innovative behavior management strategies and coordinated various clinical research projects during her time there. She's recently retired from UCLA, but we're very delighted to say that she's still very active with our organization and is one of the advisors to our Partners in FTD Care initiative. And so without further ado, I present Dr. Shapira.
Well, I hope you had a lovely lunch outside, and it's wonderful to see so many individuals I recognize, and especially new ones that I've met. First, let me introduce Dr. Wu, who is a professor of neurology at University of California at Irvine. He combines comprehensive patient care for persons diagnosed with dementia, including FTD. He conducts clinical trials, and he publishes quite a bit in the medical journals. And as you know, the speaker bios in your booklet contains more information. Dr. Wu.
Good afternoon, everybody. Thank you for coming to LA. I'm going to take this opportunity for 20 minutes to just give you a very simple discussion about behavioral variant FTDs. These are, if you read my slide, these are pretty much the common discussions I have with my patient in my clinics. If not finished in the first session, it will be in the following session to convey the information, because we really cannot cover it in one session. And after my training, I have been a practice through 5 different medical schools, actually from Northeast in Boston and the Brown University, Rhode Island, and Chicago, and actually Texas. This is my second tour come to California. I actually finished my training at UCSD. So I have patients actually around the country's 4 corners, yeah. And behavior variant FTD is actually quite diverse in a way that it's also determined by individual patient, their education, their job, their family members, ethnic different groups, their concepts. It's very difficult to kind of describe in a more general form, because every family members actually have a very unique questions. But I would just put a very general review when the general turns, and to describe, to give a very general concept about the syndrome. So the behavior variant FTD was actually a term actually has been consensus used in the past 20 years. Actually, in the old days, we don't call this. Actually, with the research in patients, particularly generally from the patients' donations of brain and also clinical descriptions, that's why we've recognized this is so-called behavior variants of frontotemporal lobar degenerations. Instead of the other variants, a language variant, another term is called primary progressive aphasia. And so that this is actually syndrome has been relatively more recognized in 80s, but in 90s we take the energy actually further defined. And in general, in the dementia clinics, this is relatively rare dementia. Most of us as experts, we actually start with a career for Alzheimer's disease. However, in the Alzheimer's research, we have to very carefully diagnose them truly in Alzheimer's disease so that we can actually do the research with them. And once in a while, we'll see a patients, they're younger patients, they're not typical for Alzheimer's disease, and this is how we kind of end up recognize the frontotemporal dementia actually is a form of dementia, unique in its way, and with different features, so that we can actually separate them from Alzheimer's disease. Sometimes easy, sometimes actually very difficult. Now, in terms of clinical presentation, in the morning, Dr. Mendes probably already described the very details. I'm not going to spend too much time. I just highlight a general concept, so-called executive dysfunctions. It's actually primarily emphasized because of a damage on the frontal lobe, and also some of them actually from temporal lobes. And in general, before we have a definitive diagnosis, we clinically just use a so-called frontal lobe syndrome before we confirm it's actually as a behavior variant FTDs. So this is a more conceptual turn as a beginning. And then we'll collect data about how their behavioral presentations, where there is a bizarre behavior, out of characters of their usual trainings or usual work, and also review the emotion and affect. And because these are all the symptoms of the disease. And then there are usually, clinically, we see them from two extremes, either too active or too withdrawal. This is actually a feature of that. And then the other feature is that a lot of them actually doesn't know they have a problem. So this is actually create quite a bit of difficulties. And then in terms of diagnostic evaluations, actually, it's not easy to make diagnosis for general neurologists, and if individual is not expert, because they may not see many of these. Everyone has a unique story. I pretty much see everyone new case every week in my clinic seeking for second opinion, and they go through a several diagnosis process. So we need a very detailed history, and the most important is that there are guidelines for our diagnosis, but we have to kind of look into all these features from the clinical history and the imaging features, and then to kind of finalize the diagnosis. So I'm not surprised that a lot of patients have went through all these processes, take several years, because around the nations, there are not many experts for frontotemporal dementia's care. So many patients actually have been carried out the diagnosis of so-called Alzheimer's disease. Some of them actually was wrongly diagnosed with frontotemporal dementia, which they don't have. So in my clinic, I had to very carefully actually differentiate the two. In terms of diagnosis tools, there are general. You have to take time, a lot of time with the family members, because sometimes patients really cannot tell you or volunteer tell you the features. And then there are other factors will mimic in frontotemporal dementia, and those are the ones actually have to be carefully kind of rule in or rule out. And the third one is very important, is the imaging study. However, the imaging study, sometimes if the doctor rely on radiology to report it, some of the radiologists, they're not expert, they will not mention it. So I'm not surprised some of the patients, they actually had an imaging study, like MRI or CAT scan. It was reported as normal or related to age. But when an expert look at it, they're not actually related to age. So we have to kind of really have to look at the image by ourselves. And then more advanced tests like PET scan, those are, if it's available, but some facility doesn't have it. So the feature of it is that if they don't show a typical atrophy, so-called in frontal part or temporal lobes, sometimes it's very difficult to make diagnosis. So that's where we have to use the PET scan. And sometimes you follow through, and they don't change. And this is actually Dr. Hodgins right now, used to be in UK, right now in Australia. He was talking about so-called behavior variance frontotemporal dementia phenotype syndromes. This is a particular so-called frontal type like dementia, but they don't progress, and which is actually very interesting and have been seen by expert clinics over years, and we still need some research about it. In terms of terminology, depends on the training, because the research in the recent, particular 10 years, we keep changing the diagnostic term based on the molecular biologies and the genetics. So the old term, the Pick's disease, still is a diagnostic term to get insurance to pay for it, but the new term, either executive functions, dysfunctions, syndrome, or BFTDs, actually we don't have a label in the diagnostic categories. That's why you will see in terms of insurance for the payment, sometimes we have to force use Pick's disease. Because there's no, when you choose in a computer, there is no such label, so-called behavior variant FTDs. In the newer ones, actually called a major neurocognitive disorder due to frontotemporal degenerations. So a lot of this term was actually in the literatures, but we are limited by the insurance-based diagnostic chosen from computers. So that's why you will see those terms show up on the paper. Because that was our limitation. And then in terms of research about genetic, a lot of people actually will say, does it pass on my family? Actually, in a specialized clinic, when they collect genetic data, many of them does have family history. But if you ask them carefully, you have to be very specific. Are they really diagnosed with frontotemporal dementia, or actually a lot of them actually diagnosed with Alzheimer's disease? So there's a concept, maybe a lot of them has family history, but in fact, in the general clinics, a lot of them, they don't have family histories. If they have family history, majority of them actually from Alzheimer's disease. But if you collect the patients in a very purified, all of them has a pure frontotemporal dementias and have more carefully asked, then you'll find there's a genetic form of them in the family. So in the literature, it says that there's a lot of genetic family history, but it's actually from very specialized clinics because they only collect FTDs, and they rule out Alzheimer's disease. Actually, Alzheimer's disease is more common, and then right now it's very easy to mix together. In terms of progressions, everybody actually changed different ways. In my practice, I've been almost 20 years. I'm very careful not to say everything I know, because everybody changes a different way in different situations from different families' perspective. In general, you will learn that from internet, but mainly it depends on patient progressions, actually, and then eventually, behavior variant FTDs, they will have language problems. PPA eventually will develop behavioral problems, so eventually they kind of merge together. By the end, when they are very severe, they have both aspect symptoms. The classifications of the behavior variant FTDs and PPA, it's actually in the beginning, but once they progress, when the brain has changed, spread the outer part of the brain, they have symptoms actually kind of merge. And once it becomes very severe, it's very difficult to tell from Alzheimer's disease. So this is actually what, if you see in the early stage, or if you see in a later stage, that how make it different in terms of diagnosis can be made. In terms of management, it's actually, even though there's no cure, but we're trying to emphasize there are behavioral issues we can manage. I think most of my role is to try to coach the family members, recognize the key caregivers or more than one caregivers to coach them about the disease, and mainly is actually watch out for their safeties and maintain their activities as much as you can. So there are a lot of issues have been discussed this morning. I actually sit in the back, and many experts already presented this morning. But I must emphasize that the key issues, keep them safe, and continue to provide the coaching to the caregivers and help them to make the decisions for every step of the care. It's actually very difficult to make decisions for the care choices. So, but most of the patients I have been taking care of, the most is the love of family. That's really make a difference. And then they actually will help them to provide the care. The medicine choices, actually, they all have pros and cons, and I usually kind of spread out what is the use of medicines, including psychiatric medicines, and what is the downside of the medicine, because there are no good choices for the individual patient. You have to judge based on the situations and different stage of care. So you need a more experienced clinicians to go with each stage of care. So far, we don't have so-called cure for disease, but there are manageable strategies and treatment issues. So I would just end here for the other speaker to talk, then we can discuss other questions after this, okay? Thank you.
Thank you, Dr. Wu. Our next speaker, Marianne Sanders, is a clinical nurse research specialist in brain health and memory at University Hospital's Cleveland Medical Center. Marianne facilitates both an FTD support group and a structured caregiver program providing caregivers with tools to understand and manage behaviors common in dementia. I'm so pleased that she's also an advisor to the AFTD Partners in Care Committee, and we value her expertise. Marianne?
Hello. I'm going to start by talking about some of the typical symptoms that people with behavioral variant FTD experience. I'll then identify the challenges that care partners have described to me over the years. And then finally, I'll move on to tips and strategies of how to move forward and approach these variable symptoms. I want to start by reminding everybody that behavioral issues are symptoms of a disease and not intentional. People with behavioral variant FTD did not ask for this, and nobody asks for FTD. It's not fun or easy to be in their shoes. It is, in fact, the caregivers, families, friends, and health professionals that have the ability to adapt and be flexible. None of this is easy for anyone. I'm going to talk about the symptoms that we see frequently, and then I will give examples from my experience to kind of better describe how those symptoms look in real life. A hallmark symptom is change from baseline personality, and this can look like a polite and considerate person becoming rude and demanding, or a quiet and introverted person becoming loud and boisterous. A get-up-and-go type person is content to sit around and watch TV all day. Poor judgment is another common symptom that's very overwhelming for families. The affected person is overly focused on doing things they're not supposed to do. They sometimes work against their care partner's wishes and oftentimes need lots of supervision. And this can look like a hardworking person who is very careful with money, starts sending a new friend they met online lots of money. Unfortunately, this new friend doesn't really exist, and oftentimes the money is gone forever. Or this is a true story, a husband who had the behavioral variant FTD and was driving his wife to a restaurant for dinner, and on the way he started running red lights, more than one. And thankfully there was no car accident. But when they got to the restaurant, the wife asked him, why did you do that? And his answer was, because I didn't want to be late. And that's a perfect example of poor judgment. Another common symptom are mood changes. An easygoing person becomes unfocused, anxious, and irritable. Or a kind and thoughtful person becomes very self-centered and selfish. Unpredictability and disinhibited behaviors are another hallmark symptom of behavioral variant FTD. And I do think this is the most difficult symptom to manage because it requires lots of patience and creativity to find ways on how to deal with this. So examples you might see are somebody being overly friendly and talking to people they don't know. They often have difficulty reading social cues when the other person is uncomfortable or is trying to end the conversation. And as we heard from another speaker, personal space is a problem. So someone might come up and come really close to your face to tell you something, and that can be startling. These patients make inappropriate remarks sometimes and not in hushed tones. They can seem childish and impulsive, and sometimes they're difficult to take out in public. Lack of awareness that there's a problem is another issue that families deal with. Patients think that they are fine. They think everybody else is wrong, even the doctor. And no amount of reasoning or explaining will change this perception. So care partners have to be creative again and come up with strategies that go around this symptom, because there's no way through this symptom. An example of this is we had a man who was an engineer and had a high-level job, was diagnosed with behavioral variant FTD and lost that job. But because his verbal skills were good and he had a large network of people that he'd worked with over the years, he was able to get jobs. Even though he had recently been fired. And one of the issues was he would get jobs across the country, and then he would just leave in the middle of the night and find his way across the country and then not show up for the job, and would call his frantic family back in Cleveland saying, "I don't know where I am, I don't know what I'm doing." And the daughter was trying to contact these employers. There were more than one. This was just one example. And these employers, she would say, "My dad has dementia," and they would think of their experience with dementia was an elderly person with memory problems, and so they would say, "Oh, this is fine, and we're going to follow through." In this situation, the daughter had to become become his legal guardian, and limited his ability to access the internet, and things began to settle down. Lack of empathy is another symptom that we see. People seem selfish, inconsiderate, and non-caring, but in reality, it is their brain disease. An example of this is a caregiver who attends our FTD support group. Her husband, so he's the affected person, they had a flood on the whole first floor of their house, and she was frantically trying to, take care of things, and he sat contentedly watching the game in an easy chair with his legs up. And, this is kind of a perfect time to remind you that even though you know that this is a disease, does not mean that you're going to handle situations well. In that situation, she was very upset. And no amount of trying to tell him, "I need your help, please help me," made a difference. Another example of this was a wife of a couple. The wife was the affected person, had been married well over 50 years, and had a very loving relationship. They were at our clinic, and he collapsed. And I'll never forget this. I thought the man was having a heart attack. Thankfully, he wasn't, and actually things worked out. But she simply stepped over his body to go over and get a drink out of the water fountain while we were all frantically trying to deal with him. And it is funny to hear these stories, but the reality that's, the sadness associated with that, where someone could think that this loving, wonderful woman was uncaring, but she just truly had a disease. The other symptom that I actually don't have the slide is that people can have very odd and rigid food choices. And they do usually revolve around sweets, carbohydrates. And the sweeter, the better. Sometimes people gain a lot of weight quickly. And in some extreme cases, the food has to be hidden. Access to food has to be limited. And even I've had situations where the refrigerator had to be locked up. And here are a couple of examples of the odd food choices that we talked about in our support group. I had a husband who would only eat Costco brand Lucky Charms. They had to be in one of those big plastic bags, and he would drink it only with Pepsi. And that's all the man ate and drank. And his wife, she tried very hard not to be out of the Lucky Charms, but at one point she was, until she went and bought the actual box of Lucky Charms. And he'd have nothing to do with it. That's what I mean, odd and very particular. I had another patient who was very focused on McDonald's chicken nuggets, but they had to be in the styrofoam boxes. And when McDonald's changed their packaging, she wouldn't eat the McDonald's chicken nuggets anymore. So because they frequented this same McDonald's, they had some extra packaging, and the husband would bring in the styrofoam, they would dump the nuggets in, and that's what she would eat. And it sounds outlandish, but when people get these kind of food not cravings, but sort of obsessions, if you don't deal with it, life can be pretty stressful. Another patient had to have or really enjoyed Kroger brand chunky peanut butter, and it was really great if it was on sale. Okay, so you also see compulsive behaviors, and sometimes this is a way people can kind of deal with some of the anxiety that they have. I had a patient that would hum nonstop, just hum, hum, hum. I had another person who insisted on singing the jingle from Gilligan's Island, which again is funny, but it really drove his wife. It's hard to deal with on a regular basis, some of these things. Walking and pacing are not uncommon. These patients oftentimes need to be moving, and if you try to stop them, it does not turn out well. So providing safe places for people to walk or pace is good. Some patients tap tables, or we had another patient that would clap. I had another patient who insisted on always having a book opened. So unless he was walking or sleeping, and when he was walking, he'd have a book. It was never a paperback, it was always a hardback book. And even if he was just sitting, if you were sitting and in a clinic with him, or even sitting across from him at a restaurant, the book would be open. So it just was something he needed to do. And apathy is the last symptom I'm going to talk about, and it's been covered already, but it's where people just don't want to do anything. They're content to lay in bed or sit in a chair, stay in their pajamas. They don't want to shower. They don't want to brush their teeth. They simply want to just lay around. And this is a difficult thing, especially if at 50 years old or in your 50s, when you've always, been focused on a career and busy and kids and family. That can be hard to deal with. Okay. Challenges. This is a rare disease that affects younger people, the prime of their life. unless you're fortunate enough to be evaluated by a physician who is familiar with frontotemporal degeneration. These poor patients are misdiagnosed or as a psychiatric disease, or sometimes dementia isn't even really thought about because memory isn't a primary symptom. They can pass a lot of the tests that are given at a doctor's office. There's a test called the mini mental status exam that looks at memory and orientation. These are not things that these patients have difficulties with, so then dementia is ruled out. Well, in fact, dementia is the problem. Family relationships change. Financial problems start because oftentimes the affected person loses their job. The ability to parent changes. Children struggle because they don't understand why mom or dad, who look perfectly normal, are behaving so differently. Friends, so you see real friends that are going to stick by you, and those are the people you want to focus on and let help. Other friends, people have a tendency to stop with invitations. Okay, so let me go down to the tips because I'm running out of time. Okay, so let's see. What to do? Okay, accept that this is your new reality. It's so easy to roll off my lips. It's so difficult to do, but this will move you forward. Learn as much as you can about FTD. Attend an FTD support group if you have one in your area. This is where you will get the best information on creative strategies. Okay, so definitely, and if you don't have one in your area, online or via phone, be flexible and understand there are going to be good and bad days. Provide structure and routine and support. This is comforting to people, and this is where if you have a familiar and structured routine, people are usually better with showering and dressing and those things. Expect change. Set up a great a strong medical team of professionals that are familiar with FTD, behavioral variant FTD. Be aware of your facial expression and tone of voice. Motivate with enjoyable activities and favorite things. So motivate, sometimes people like M&Ms. If you take a shower, we'll have M&Ms. It sounds childish, but it works. Or if we do this, we will go, wherever, McDonald's or anything that you can think of. What works today might not work tomorrow, but it might work the next day. So, hang in there. Try not to rush. Rushing creates stress, and with stress, these patients don't do well. Avoid situations that might be overstimulating or stressful. Okay. Become familiar with, you need support. We talk about the need for support at the beginning of once the diagnosis is given. AFTD has phenomenal resources. I'm sure there are brochures and things, but there are also, there's somebody to talk to, there's online resources. Consider supportive counseling for the care partner, and reach out to family and friends to help. Advocate. One of the biggest jobs of the care partner is to be advocating that the affected person gets everything they need, especially respect, dignity, safety, and quality of life. Thank you so much.
Our final duo, Amy and George Shives. Amy Shives spoke this morning. Amy earned a master's degree in education, worked as a child therapist, and was a tenured faculty member in counseling for 25 years prior to her diagnosis of FTD. She actively shares her expertise in advocacy by serving as a patient representative, as she's talked about this morning, within the FTD think tank committee. She speaks nationally and helped plan today's conference. Amy and George have been married for 35 years. Please welcome them. The shoes. Applaud the shoes.
Uh-oh, she's back. I will be speaking today. This is my husband, George. I have behavioral FTD, and mostly I do the speaking. And that will remain the case. He will be up here, and if you'd like to ask him questions when we go to questions, you certainly can ask what it's like to live with me. My daughter and best friend are also here. I just have one comment I have that came to mind is Kit Kats, fun size only. I like them on sale, and I send my poor husband to the store to buy them whenever I've run out. And that's funny. It's okay. I was not that. We have 2 daughters, and I actually did not do that when I was pregnant. So this is special. Kit Kats, fun size, and I'll be personal. 50 pounds of this is Kit Kats. Okay? So I've always been addicted to sweets, and I totally believe that I've had FTD my whole life. My mother did. But I've always eaten the sweets, and my family's here. But I've been told that I need to exercise more, and okay, but it's got nothing to do with what's in my head about the sweets. I think that was everything I wanted to say before unfortunately, I have to read this and put my words on paper. I am Amy, and if I'm redundant from this morning, I'm sorry, but I'm not talking long, so it's okay. There are some of my words are in your booklet. I wrote the train article in there, so those are some helpful, hinty stuff that's less what I'm doing here. And I am not responsible for finding the train. I think Matt O. found the train, and I thank him. I have the ability to say a train, and y'all will find that. What I have written in that article reflects the beliefs I have gained from working in my roles for many years advocating and educating for people with dementia. Nonprofits and other agencies, as well as the general public that serve to address issues of dementia, are focal points I address. I have had a long and far-reaching career in doing so from many media vantage points. I also have FTD. I've done some neat stuff, not as neat as our wonderful actress that spoke earlier, but I have done some neat stuff. I am an early stage advisor for the Alzheimer's Association, retired. Neat stuff there. I mean, I was on HBO. I did not get it. I was not credited because I was not as interesting as the other people. We reviewed TV pilots to get input from people with dementia as far as was it appropriate. They weren't. And none of them got to that point. But we as a committee of people with dementia were able to review TV pilots. I'm not in any kind of field. I wish I was. I had an AP article on myself, local media stuff, and why do I say this? Because this is a possibility. Again, it's not important that I did it. I was able to be a consultant on the 60 Minutes piece that will be on Sunday night. I was not filmed. One of my friends that you saw last year do the keynote was filmed. I haven't seen it, but I did get an hour conversation with a really top producer in 60 Minutes. which was really neat. I'd never spoken to a man, a person, woman, that was a main producer, not an under producer. This guy's, his name was Rome, and I Googled him, and he's very important. But what a neat experience that I would not have normally had in my life. Our role as persons with the disease, being fully involved in the trajectory of our lives, has to be the utmost importance, furthering any progress we, as a community-wide group of people, will make to address FTD successfully. We, who have the disease, have the best information to be had to develop any plan. It is disturbing to our community who have FTD that we, very often, if not always, are excluded at the onset of many, if not all, plans and educational materials. Ask us before you begin. If you miss that step, start again. As I stated this morning, AFTD has embraced this issue of inclusion of people diagnosed. This is an ongoing process, of course. Others working on the inclusion, not so much. I believe in the following quotes as my personal truths. And I promise you I can't quote the person. I've been told I did one of them. I do not claim it. But they are my personal truths, and I think you'll like them. Quote, we are people with the disease. We are not the disease. Secondly, nothing about us without us. And that is the main battle for me. Nothing about us without us means that, yes, we are the they, and I'm the they today right here, but we're all individuals. We are not a they. We are individuals. Of course, when speaking about people with the disease, you got to use that term. But I'm here to say that we are way individual, that you will never find another Amy Shives, and that's good. I began my process of standing here before you as a daughter of a mother who had undiagnosed FTD. My childhood was the pits. What we all are is a culmination of what experiences and our reactions to them came before us. My mother, who had most, if not all, behavioral FTD symptoms, was just mean and unattached, we surmised. This was my experience growing up. We could not have learned to have had any helpful insight in that era. I'm 61 or 2, I don't know. And, that was many, many, many years ago. No one knew, other than she was mean, what was wrong with her. I believe I've always had the disease. I have had a broken brain all my life, and I think some of the people that know me can testify that. Just briefly, early childhood, hard enough. Everybody's got their deal. Everybody's got their unusual growing up from another person, and I had mine. Early childhood, I was the kid that was annoying. I was the kid that wasn't, I was fat too. But so you don't get picked for things, and you don't, you all know what I'm saying. I was that kid. And then I didn't have any support at home. So if you're going from being that kid and you're going home and not feeling that you're loved, that's not good. In teen years, I think I was as colorful as most teens. I really don't have anything special about that. Teens have problems, and I had mine. College, I was colorful. And my best friend of 40-some years, who was my freshman roommate in college, is here to tell you I was colorful. I had really fun. I had a BA in Psych. Now, I loved my BA in Psych, but not a lot of jobs in a BA in Psych. So I went on for a master's degree, and why that's interesting is that I didn't have the grades to do that. I'd had a lot of fun, and that was my choice. And I'm not that great at being book smart, truthfully. But so I went to see my mentor, a wonderful man. He used to wallpaper, my professor, he used to wallpaper his office with fake degrees on everything he could go online and pay their money, and they'd send him a certificate. He had the doctor of, and he had a whole wall. Anyway, I went to see him, and I said, what the heck am I going to do? I'm graduating, I have a BA in Psych. He He says, well, you could get a master's. I said, now you know I can't get a master's. I barely got B's in your class. He says, well, I know of a master's there is, but you have to talk to this guy. You know, those people that talk, they don't teach, they just talk all the time. I said, I can talk. So I go off to him, and it turned out I had 15 people in the college to interview me for the master's in education that I got. And I got in, of course. I didn't have to take a test. I just told them exactly what it was that I thought I could do for them. So, you know, that's colorful. I have a family, I have a husband, I have kids. My kids grew up with a mother with FTD also. My other daughter, who's not here, it's a struggle. It's a struggle, as we have spoken about today. This is good. My career was social services. I was a child therapist with play therapy. I worked with domestic violence victims and survivors. I did a lot of emergency stuff. I was a counselor, and I have a point for this. I was a tenured counselor in a college for 30 years. Why that is important is people that are tenured have to do everything, whereas the specialty people who go teach a certain subject have that. They have 3 hours of that, and then all of their student things, if they're adjunct. I was tenured, which means I was up for anything. Go run over here, this man has taken too many drugs, figure out who we're going to call. This person needs a behavior contract or they can't go back to class. Over the 30 years, I've literally done everything. And anybody that was a victim of domestic violence any particular day, when there were a lot, had to come see me. So it's relevant because, I'm sure I'm long, it's relevant because with behavioral FTD, as that increases in symptoms, you can't really respond as well to the people that you need to not get excited at immediately. I started to get excited at things rather than use my wit and my abilities to be a counselor that I'd been successful with. I told them what I thought. I told them what I thought, and that ended my career. I did nothing poorly, but I was pulled away and told. And actually, some of my peers called my husband and said, "What's up with her?" And that's sad. Then I went on to years of abuse from medications. It's been because I was initially, atypical, Alzheimer's. So what I think we've heard today also is you get diagnosed eventually after years, and then you're sent home to die. And message being, stop at the attorney's office on your way home. So I came home and I sat down and I said to myself, well, this isn't going to work. And I stood up. And here I am, such as that. Now I have aphasia, I have seizures, and et cetera. I'm very grateful to be a volunteer at an adult day center in my town. Any fragile adult is welcome to attend the center as little as they wish, or as more. It's lovely. What I want to convey is this: people will seek you in a manner that you must seek out. They will speak to you in a manner that you must seek out. We are charged with attending to this communication. When I see a nonverbal client seemingly struggling, it behooves me to make my best attempts to help. What I do not do is to react only to the overt behavior the person displays. I do not greet them with yelling or crying myself as they are, if they are. I seek to understand. I walk over to the person. I engage them at their level emotionally and physically, and do my best to determine the need for the moment. I assume that they know what they need. I know what I need. The person with dementia does know. The prevailing issue is that we must figure it out. I have found that most of the time, the client with dementia wants a glass of water or a bathroom break. Thank you. Think this is mine? I'm not sure.
Thank you very much. Now we have questions. Lots of little papers. So, is someone coming up this aisle, this middle aisle? Okay, we'll do a simple question while I'm reading through these. How do you lock a refrigerator? Oh. There are microphones there.
Okay. Actually, that's you. Hello. I'm so bad with technology. Oh, good. Here we go. The answer is I don't know. So I know that one person got a sort of a bicycle chain type thing and was able to create a situation that the person couldn't get in the refrigerator. So in some ways it's setting up something that can outsmart the person.
I can get in the refrigerator.
I know. And this is such an extreme example, and it's when the eating was becoming, almost dangerous for the person. They would just eat until they were sick and not stop. So. Okay. Oh, good.
The second question for Dr. Wu, can a concussion lead to behavior variant FTD? I think that's relevant because we've all been hearing some of the issues revolving head trauma in sports. So.
It's more happening in the football players. They have very repeated concussions, so the clinical syndromes is characteristic like a frontal-temporal behavior variant FTDs. There are a syndrome like that. But a simple concussion, not like the football players, infrequent, maybe one time, they don't lead to behavior variants.
Okay, this could be for anybody on the panel. I think this is a very relevant question. My sister has behavior variant FTD, and we're finding that her doctors don't talk to one another. How can we get one of these healthcare providers to take charge of her care, and who would this person be? Who would like this?
I would say a lot of doctors there in community are afraid to take care of FTD patients. I think that's the reason. And usually the current healthcare system, they don't allow the physician take a lot of time to questions. And so they really, the best way is actually refer to the specialized center. They have more care, support, staff and expertise and doctors.
I think that's true, but often people live in areas that are not UC San Diego or Cleveland Clinic or some of the other Minnesota. So what can we do? What can people do to advocate to get the care? Marianne?
Okay, I very much agree with Dr. Wu that getting to a professional who is experienced in FTD is very important. The communication piece between one doctor to another is oftentimes becomes another job of the care partner. I mean, if you're in the same bigger hospitals have things called the electronic medical record, and so most communication is kind of in one place. But if you're at two systems, making sure that, like for instance, your primary care physician has notes and progress notes or updates from the neurologist or psychiatrist, oftentimes becomes need the records, a medical release, and either having them sent or faxed, and then making sure they actually get there. It's an effort, but it's enormously important.
Right, and I'd like to add, I think that we have a right to sit down with the physicians and ask them directly, I need one person I can go to. Can you maybe start with your primary care doctor, the one that you feel most comfortable with, and ask, who can this person be? Will you do that for me, or where can I go? Okay, Amy.
May I just comment briefly? My best care has been since I have been affiliated with UCSF. I'm a lab rat there, and I get all of the testing done that you heard about this morning on longitudinal studies. So, that's the best care that a person could get. How much care do I get in Spokane, Washington? Zippo. How much conversation have my caregivers had? Zippo. I go in and see my physician about nothing. And it's, oh, you have FTD? Well, I've seen him for 2 years. It's hard.
That's a very good point, like connecting with the research study if you can. Amy and George, I think this question is for you. What do you tell your spouse with FTD who most of the time is unaware of his condition, about his condition? Do I share this booklet on FTD with him? Do I show him the stories of people with FTD? George, do you want to start with that?
I think it's on now. I think you have to gradually approach the issue. I think it's important that you face the challenge that's there. Your spouse has a problem, that you make them aware of the issues, but you're not being critical. You're not scolding. You're not necessarily trying to redirect at this point. You're just looking for them to hopefully accept the awareness of what they're doing, and then over time, I think you can move forward. And if you could make some headway there, then you can start looking at the medical aspects of it. You can start to maybe help guide them, set up some guardrails as I look at it, so that they're operating within a reasonable range. If you push, if you try to parent, I think you're going to end up with more problems.
Thank you. Dr. Wu, you can start with this. My husband has continual waking bruxism, which is grinding of the teeth, accompanied by wincing and muscle tightening for the last year of his life. Is this a typical symptom, and is there a treatment for this?
It have to be very careful to differentiate the behavior, whether there's come from the brain or from psychogenic. So it have to be assessed by expert. Yeah.
So, okay, you couldn't really hear it. You have to evaluate where it's coming from, and you have to evaluate the teeth. But Marianne, do you have any specific things that you have used with your?
Interestingly enough, there was the person who ran the red lights had this symptom, and there was a medicine that was tried. I don't remember exactly what it was, but it was ineffective.
So bruxism and the teeth grinding, as we've said, it's one of the repetitive behaviors that we see, and like part of the Kluver-Bucy syndrome also. And sometimes I've seen it's helpful to use, pet toys. I mean, like rubber chew toys, but you have to take out the squeaking part so you don't. Well, not just to not annoy everybody around you, but you can swallow it. So, but it can be extremely, grating on the teeth. So if this behavior occurs, make sure there's good dental hygiene, because the teeth can wear down, and it could be caused by pain.
There is, actually, now that you said that, there are some like chewy type things that are used for people with autism.
Yes.
So a website or an online, looking at through it that way, you can get some sort of adult chewy type things.
Okay, here's a, I don't know who wants to take this one, but I think it's interesting. What environmental factors help cause FTD? The speaker was talking about environmental and genetic causes. What is the proper term for FTD, dementia versus frontotemporal? Dr. Wu?
Two questions. Environmental factors not really established so far. Certainly, a lot of people speculate. Depends on your environment, but so far there's no substantial data to support any particular environmental, either chemicals or the physical. The other question is
The proper term, so I'm reading that as where do we place FTD under the umbrella of dementia, if dementia is the umbrella term?
Dementia is the term so-called impairment of the cognitive behavior. FTD is one form of dementia.
Yes. So yes. Did that answer that person's question? The umbrella term is dementia. There are different types under that umbrella term. Alzheimer's is one type. Frontotemporal dementia is another one. Frontotemporal lobar degeneration. Then under that, we have the subtypes: behavior variant, PPA, semantic dementia, PSP, CBD. I hope.
First, that question was, what are we calling what we have? AFTD, and we'll see dementia anywhere in the name. And my question is, do we say dementia, or do we say that, something else? Because people get dementia, and they immediately have a total different reaction. And I don't think, as an FTD, I'm in that boat, and I don't think a lot of people here are in that boat. So, and today, in the meetings, I've heard some of the speakers call it dementia, and some have called it frontotemporal degeneration. What is the right name?
They will use the name in different way, depends on the audience. So in a simple way, dementia is a general term. It seems most people accept that, but some people don't like that word. Frontotemporal lobar degeneration is a creation based on what we see actually in the brain. They're losing brain cells. It's a more like formal term, but you have to have actual see it. For example, MRI really show a change in the brain. So it's a more academic term. So in order to not use dementia, using the more physical descriptions, that's why I use the frontotemporal degeneration disorder. Dementia, it's a general term for general description if people accept that. So you kind of use in different situations with those different terms.
But this is your disease, and if the dementia doesn't describe you, you have a neurological condition. It's called frontotemporal dementia, frontotemporal degeneration. So it's your disease, and you use the term that makes sense to you. I hope we answered that. If not, there's another longer session for questions and answers at the end of the day. Has behavioral variant FTD, what is the timeline progression if we are already having speech problems, only known that there's FTD for 6 months? So I guess this is talking about the overlap of symptoms?
Yes, so behavioral problems and the language problem in frontotemporal dementia, sometimes they all come together. But in terms of prognosis, really is individually have to be judged. There's no so-called timeline. I've seen people live with it for 10 years, some people more short period of time. It's really about care. So if the person not taking care of personal hygiene, nobody they provide the care, they get into accident, they can fall, they get into standing in the middle of a road, then you can kill with that. Yeah. But if you have good care with the good protections, they can, because disease itself does not kill you. It's actually make the patient vulnerable. So if you can help them to protect them, the general health is help them to avoid diabetes, heart attack, cancer. These are all kind of good for them in terms of lifespan.
Our last question, and then we'll end the session. Marianne, I'll let you start with this, and then if anyone else, if you want to pipe in too, you may. Is increasingly juvenile behavior in FTD common? My husband is at times more like having my 5-year-old son back. I flip between being a mother and wife from moment to moment, trying to be patient with behaviors that are constantly changing and are uncorrectable.
The answer to that question is yes. that people do, you do see childish behaviors pretty frequently. And it's extremely difficult to accept an adult behaving in a childish manner. But it is part of the disease, and what can be a bit of a problem is if the husband is kind of horsing around with the children, another child, and sometimes the horseplay gets out of hand, you know what I mean? Because this is a big, strong man playing with one of their kids. So, you know, understanding and you know, keeping an eye on that situation is important. But it is, it's very familiar for men and women. I mean, common.
So I think this session is over. It's 2:30. It's time for the next break, and then on to the final series of sessions. So thank you very much to our panel.